So, but anyway, we're going to be showing you today some of the infectious disease cases and part of tropical infectious diseases as well of all the cases I saw during the Gorgas course in Peru. And I hope you find them as interesting as I do. This is me. And just to tell you a little bit about me, those of you who don't know me, but I graduated in Costa Rica, and I practiced working in primary care there for several years. I'm currently doing an MPH, which is a Master's of Public Health and Communicable Diseases here at USF. I'm finalizing, and hopefully I'll graduate by the end of this year. And I recently acquired my DTMH with the Gorgas Memorial Institute, which is an affiliation with the University of Alabama at Birmingham and Universidad Peruano Cayetano Heredia in Lima, Peru. And this is where all the magic happens. So this is just a portion of the hospital. Down here are the labs. Here are offices and immunology labs. But this is a portion of the big part of the hospital. And this is the Tropical Medicine Institute. This is where we would actually see patients. There's a 36-bed unit here at the Infectious Disease and the Tropical Medicine Institute. And we would see it all. We'd see the patient. From the patient, we'd examine the patient. We'd go to the path lab if there was a biopsy taken of the patient. If there was some kind of slides to be seen, we'd do it all here. Okay. So why do I have this organism up here? Cyclospora cayetanensis. If you recognize, this name sounds like Cayetano Heredia, and that's because this was actually discovered there. So they're very, very proud of the fact that they discovered this organism. These were my mentors. This is Dr. David Friedman. Dr. David Friedman is out of the University of Alabama, and he's the one he actually created the GeoSentinel service, where it's a large database of ill travelers around the world. So he's the one who's kind of seeing where are these diseases popping up in what parts of the world and how to control them. Dr. Eduardo Gotuso is a very good friend of mine. He's from Peru, and we're very proud of the fact that during the Gorgas course, he was named as a recipient of the award of Carlos Slim. Carlos Slim happens to be one of the richest men in the world, and he gives a health award every year to somebody who's who works towards bettering the lives of people around the world, especially Latin America. And he's done a lot of research in what is HTLV1 and tuberculosis. So we're very proud that he won that award. So this is a map of Peru, and these were the hospitals, a list of hospitals of where I actually saw patients at in Lima, which is right here, and then Cusco, which is further down here, close to Machu Picchu, and Iquitos, which is actually in the jungle up in the north. And you can see that the Amazon River is up here. So Peru, the reason why I put this map of Peru is because Peru actually has a very interesting topography that no other country in South America has. And Peru, actually, the coast is all desert. So you see certain diseases that are just acquired in this area. Then in the middle, if you can just imagine like making stripes, 3 stripes, you have the middle stripe, which would be the Andes Mountains, and you see a lot of diseases which occur there, such as hydatid disease. And then in the Amazon, you're going to see diseases vector-borne by mosquitoes, such as dengue, malaria. So it's actually very a unique place to go and study tropical diseases for that reason. So I'm going to start with the most prevalent of the diseases that I saw in Peru, which is leishmaniasis. And it's a protozoan disease transmitted by the sandfly, and we're going to be seeing the sandfly in a second. It's on the World Health Organization list of neglected tropical diseases, as are the following diseases that we'll be seeing after leishmaniasis. And there's an estimated incidence of 1.5 million new cases a year. So there's a heavy burden of leishmaniasis, especially in Latin America. The forms that I saw, leishmaniasis entails a lot of forms, but the forms that I saw most prevalent were cutaneous and mucocutaneous. So we'll be seeing pictures of both of those. And because it's the New World, we're going to be talking about these which Peru hosts. So Leishmaniasis brasiliensis, guyanensis, and peruviana. And they have their specific areas where they like to pop up. So this is the New World geographical distribution. In Latin America, we see it's a big portion, but surprisingly, there have been cases reported by the CDC that have popped up in Texas and Oklahoma. So it wasn't clear if these were probably, most likely, immigrant cases from Mexico. But you can see all Central America, most of the portion of South America, with the exception of Chile and Uruguay. And this is Peru. Okay, so just to remind you of the life cycle of this parasite. So the sandfly, which actually is not a fly, it actually belongs to the family of mosquitoes. And so I'll be showing you a picture of the vector. But the sandfly comes and takes a blood meal off of a human. So what it injects are promastigotes, which are these little critters here with a tail. And that actually goes into the bloodstream of the human, and these promastigotes are phagocytized by our macrophages. So they go to the macrophage, and what happens? They transform into amastigote forms. And when the amastigotes replicate, so rapidly within the macrophages, these burst, and then they disperse to other areas of the blood. So when a fly comes, a sandfly comes again and takes a blood meal, it takes these forms of the parasite, and in the gut, they actually transform into the promastigote form again. And so that's how the cycle is. So the reservoir of leishmaniasis, it's believed to be such as marsupials, like the sloth in Costa Rica, and the dog, possibly. So it's really unclear, but if this sandfly bites the dog and comes to the human, so we have the cycle here. And then you could also have the from human to human transmission. So this is the vector, and it's called Lutzomia. And you have different species of the sandfly. You have also phlebotomine, but that occurs more often in the Old World. And this is just in the New World. So, people are usually, you can see, this is full of blood here. And we were actually in the lab, in the insect lab, and we could see them up close. And you can see how tiny they are. This was a really, taking a close picture of them. They usually, let me go back and mention that they usually bite when you have a risk of getting leishmaniasis is usually at dawn and at dusk, and that's when they end up biting. And they usually don't like to bite unless they've been, disturbed in some way. So usually you see them when people work in the jungle and they're cutting down trees. That's where they usually get bitten.
They're very small. Here in the U.S., I guess we have sandflies. They call them the no-see-ums that you see, that you don't really see at the beach that kind of sting you at dusk and so forth. Was it easy to see them kind of flying around? And while you're answering that, I'm just going to make sure, I'm going to check something in your presentation.
Sure.
Go ahead and answer.
Like I said, these are really tiny. And a lot of people, when we talk about prevention, a lot of people think of, well, they can use bed nets. But the reality is some of these bed nets, the holes are so huge that these little mosquitoes fly through. So bed nets are not really of much use. And the other thing is, if you ever think about it, you see in Latin America they distribute these bed nets. And these bed nets are really, you think, well, sleep under a bed net. But if you've ever tried sleeping under a bed net, it's actually very uncomfortable. And especially with the heat. So you end up seeing them using them. They give it to them for free, and you end up seeing them using them for curtains in their house. And so it's a little frustrating because you're like, they're supposed to be using them for sleep, but they don't. Okay, so this is a distribution map of the leishmaniasis species that you can find in Peru. So Brasiliensis is the most resistant and the most aggressive of all of these. And the dot is in green here because this is all the areas where you can find it. So you have some isolated areas here, and you have throughout all of this area, which happens to pertain to the jungle. And Brazil is right here, Brazil and Bolivia. So the Andean highlands is host to Peruviana, which is a more milder form. It's not as aggressive as Brasiliensis, and we'll see that in some pictures I'm going to show you. And you'll see that that's mostly located towards the coast and the Andean mountains. This is the leishmaniasis clinic. That's how prevalent it is in Peru, that they actually have a clinic dedicated for the treatment of patients. And these patients come from all over Peru. The structure of, this is the only good picture I could find of the clinic. They've done some kind of construction to it, so it's not as small, but even if it looks insignificant, big things are happening there. And they're treating tons of patients every day, and they're doing studies on leishmaniasis, so it's pretty incredible. So this is one of the patients that I saw actually in the clinic. And her case was interesting because this girl got infected while being pregnant. And so we couldn't start treatment on her because she was pregnant. And pentavalent antimonials, which are the treatment given in Peru, can be harmful to the baby. So she had to wait until she gave birth, and then she started her treatment. So this was the day that she was going to start treatment. But you can see, how disfiguring this disease. The tissue's very granulomatous, and the crust that forms. So here, we always look inside their nose to see if they have any kind of perforation to the septum, because leishmaniasis likes to attack the soft palate, the hard palate, the nasal mucosa, and even the vocal cords. So here we're just checking to see that there's no illumination to the other side to make sure she doesn't have any perforation in the septum. But you can see that she has this granulomatous tissue inside as well. So cutaneous leishmaniasis is located usually in any exposed areas of the body, but most popularly you'll see it in the nose, the cheek, the forehead, and other areas. The incubation period can be anywhere from days to years. It's a painless lesion, which is pretty amazing because when you see these lesions, they're just so impressive. We'll see one that's an ulcer more up close. These are generally self-limiting, but what happens is that if you don't get treatment, they can become chronic and progressive. And then the latency period, if you have one of these lesions on the nose and don't do anything about it, eventually in 2 years you'll develop mucosal lesions. So another case of cutaneous leishmaniasis, again, you see the person has the nose affected, and he does have perforation of the septum. So you can see as we illuminate one side, you can see the light coming out on the other. These babies were so cute. So, it's so sad to see that at such a young age, because even if they do get treatment for this, they're going to have a mark on their face for the rest of their life. So this baby had it on the forehead, and this child actually had previous treatment with antimonials, and you can see this was the initial place of where she got bitten, and she received, I believe, 2 cycles, and she didn't get better because now she has this satellite lesion which appeared here. So in talking with her mom and trying to get history, it was pretty fascinating because as we sat there talking to the mom, her mom also had a lesion much tinier than hers, but it was obviously, she didn't do anything about it, and it had cured on its own. So the mother had been exposed as well. This is a very rare form, and we were very lucky to see it. This is the varicose form, and you can see it. It looks like cauliflower. And it's very hard, very crusty, and amazingly, it's not painful. So this was a young boy. He must have been 8 years old, school age. This is one of the most impressive lesions I saw. It was a 25-year-old male. He worked as a chef, standing on his legs many hours. You can see this large ulcer. He said it was a very tiny ulcer, and it became this large after many, many months. So he must have had some kind of very aggressive form of species of leishmaniasis. And here, how do you diagnose this? He was there to start treatment. So before starting him on treatment, they were including him on some kind of study. So what they did was a filter paper impression of his lesion, and you can see it's very wet. And this gets sent to the lab for PCR, and that's when the species gets, in other words, identified. And it's really important to identify the species because it depends how they're going to respond to treatment. So we want to know if it's a resistant type of leishmaniasis, if it's it's going to be chronic, progressive. So it's important for this reason. Then we have the doctor, after he had injected some lidocaine into the patient's ulcer, he took a punch biopsy, and this gets sent to the path lab so that they can see exactly what's going on. Sure.
First, is this form painless as well?
This was painless to him. This was painless. It can become painful, and I'll show you when it becomes mucocutaneous, when it's affecting the oropharynx, the nasopharynx, and further back into the vocal cords. So it becomes painful.
And you said you can do human-to-human
Yes. If a human is infected and doesn't do anything about it, and for example, if he would go to the jungle and just be hanging out, and a sandfly comes and bites him again, and then that sandfly goes and bites somebody else who's not infected, they would eventually develop probably the infection.
But direct person to person?
Oh, if you touch it, no. You would have to be inoculated it's a vector-borne disease, so you'd have to be inoculated. Correct, yeah. Because remember, the form that you see in the human is the amastigotes. So this was actually from one of the samples from one of the patients, and these are all red blood cells, but these are macrophages, and each of these macrophages, each one of these dots is an amastigote. So, and you can see they explode, and there's some of them floating freely. And how do you diagnose this? Besides seeing this on a slide on a GIMSA stain, you can grow the promastigotes in cell culture. So, and that's how you can be sure that the patient is really infected with leishmaniasis. So these were grown in cell culture, and you can see the promastigote form with the little tail and everything. This is the mucocutaneous form. And this patient, it's a very sad story, but amazingly a very happy person. And he was proud to show us his lesions, and he told us his whole story about how he had to escape from his employers in the jungle. And he's actually from the Andean region. He's from the Cusco province, a place called Sequani. And he had migrated to the jungle as a young man. He must have been 20 when he first got the lesion on his nose. So he never could do anything about it because his employers never let him access any health care or go to the city to get help. So eventually it developed, and it affected all of this. You can see there's no uvula here. The destruction is absolutely amazing. And no septum as well. So this has to be totally reconstructed for him, to change his whole disfigurement. And we saw all of these patients in a clinic in Cusco. This person had vocal cord involvement, and he had I wish I could have recorded his voice now that I think about it, but he had a very raspy and horsey voice. So it doesn't hurt them after they're treated, but the scars are there for life. So, it's really something that we need to try to avoid from happening. This is me with the man that we just saw in the prior picture who had vocal cord involvement, and it was an honor to take a picture with him because he's actually the president of the Leishmaniasis Patients Association of Sequani. And he's a farmer, and what he does is on his weekends and spare time, he'll go out, he'll dress as a mosquito or kind of like the sandfly, and he'll go to different villages in his area, and he'll explain. He actually advocates for the disease. So he's like, if you have a lesion, recognize the lesion, go and see a doctor, get health care, because otherwise you can end up with sequelae like I do. So it was actually really an honor to sit there and talk to him. This is Dr. Maria Cruz, and she's actually the leishmaniasis expert in Cusco, and she travels very often to his town to see these patients, and she knows them very well, and they have a really good relationship. They have total faith in her, and she's done a lot for them, so she's as well a hero in my eyes. The diagnostic approaches to leishmaniasis, well, recognize the clinical. If it looks like it, then you have to suspect. Epidemiological, do they come from the jungle? What part are they, are they exposed to the sandfly? All of these things are important. But what's going to give us the confirmatory diagnosis is looking at the parasites, seeing the amastigotes on a slide or in tissue, growing those promastigotes in culture, and then also doing a PCR just to make sure. So these are the different types of treatment, and I didn't see any of these happening. But mostly treatment depends on the species you are treating and the size of the lesion. So if it's a small lesion, usually they prefer local, and they do some kind of thermotherapy with a machine that they apply to the lesion, and they'll apply 1 to 3 sessions with localized heat at 50 degrees Celsius. I don't know what that is in Fahrenheit, but it's much higher than 100 degrees for 30 seconds. And it does help. It does help if it's a small lesion. But we'll get to another study that they're doing that shows that there's a better outcome when you treat differently. Then topical paramomycin and gentamicin has been seen, but this is mostly with leishmaniasis in the Middle East, like L. tropica, but not really with the species seen in the New World. Intralesional antimonials can also be injected at the site. What I saw being used mostly was systemic treatment. So pentavalent antimonials are the treatment. They use mostly sodium stibogluconate, and they usually use this for 20 to 30 days, depending on the lesion. If that doesn't work, they usually try anywhere from 1 to 3 cycles, and if that doesn't work and the patient still is resistant, they'll move on to liposomal amphotericin B. And Peru, the government of Peru actually gives these medications for free, so the patients don't have to think about any kind of expenses. This is...
Come and get the IV every day, or they stay inpatient every day?
No, they come on an outpatient basis and they receive treatment. If it's amphotericin, they get an infusion, and usually they are hospitalized here when they're given amphotericin. But if it's sodium stibogluconate, they're on an outpatient basis. They come every day. This is a randomized double-blind study of glucantime IV, which is another medication that is used, and topical imiquimod, which is actually an immune modulator used in HPV, human papillomavirus. And they've tried this in 40 patients in Peru at the IMT clinic. And this is the outcome with leishmaniasis peruviana, which I thought was very interesting. These patients came, and in order to be included in the study, they couldn't be pregnant, they couldn't have any mucosal involvement, and they had to be resistant to some kind of treatment, had a prior treatment and were resistant. So here they applied imiquimod to the lesion every other day. This was the baseline, and this is at the end of treatment. So these patients received 20 days of treatment, and you can see this is how it looked in the beginning, and then this is how it looked after the 20-day treatment with glucantime IV. This is where treatment stopped with both imiquimod and glucantime. And these patients continued having their follow-up on a monthly basis. And you can see that even if it wasn't being applied, they had a cure. So that's pretty amazing. The problem is that imiquimod is very costly for the Peruvian healthcare system to buy. So they wanted to prove that this could be used safely on patients, and really the only adverse effect they saw in patients was erythema. And so you can see, and this is with a placebo, and you still have scarring after 3 months. The same thing was done with patients who were infected with Leishmaniasis brasiliensis, which happens to be more resistant and more aggressive. The same thing, here's the initial lesion. This is after treatment with both things, and then the follow-ups. Okay? The other disease that I saw was leprosy. I saw patients in Lima, and I saw patients in Iquitos. And this patient we saw in Iquitos, it was one of our last days of rotation. And he was coming in. He was very scared. He didn't know what he had. You can imagine, if you have these bumps on your body, they really, they don't come to the doctor because they're fearful of what the doctor is going to tell them what they have. So this is an infection caused by Mycobacterium leprae. And the root of infection hasn't been proven, but it's thought to be respiratory. So if he were to sneeze, we could get it. Okay? But it may take 2 to 10 years before the signs and symptoms appear in a person. So what gets affected in leprosy? It mainly affects the skin, the nerves, and the mucous membranes. And the disease can cause lesions that can be faded or discolored. We'll see a case of a patient who had those. Growths on the skin, such as these little things. Thick, stiff, or dry skin. Matarosis, which is loss of the eyebrows, and you can see that he has that there. Numbness on the affected areas of the skin, muscle weakness or paralysis of the hands and feet. They can have eye problems. They have loss of sensation of the eye. Enlarged nerves, which you can actually palpate in them, and a stuffy nose and nose bleeding. The curious thing, this is Dr. Pedro Legua, and he's one of the leprosy experts at the Gorgas and at IMT. And he told us that most of these patients start with lesions at the chin area, and you can see that he has those. So this is the classification for leprosy, just to remind you. This is usually indeterminate, tuberculoid, borderline tuberculoid. These have very low bacillary index. So you're not going to find the bacilli very easily. With mid-borderline, borderline lepromatous, and lepromatous, which are the majority of the cases I saw in Peru, you're going to have a very high bacillary load. So you can see up close the first patient who was very scared of receiving any kind of treatment, just how it deforms and disfigures your anatomy. It's just incredible. You can see some here. This patient we saw in Lima, and he actually, we're seeing him here post-treatment. And he has matorosis as well. His lesions, unfortunately, you can't see it very well, but he has hypopigmented lesions. And some of the lesions actually left like an indentation in his skin. Here, Dr. Legg was actually testing him. You actually test their ulnar nerve to see the strength. And do you mind if I get that piece of paper? It's actually to see the strength of their ulnar nerve. So you put the piece of paper in between these two fingers and you pull. If they're able to grasp it, it means they still have the ulnar nerve intact. If they don't and it easily pulls, then they have, it's affected. And his was affected, obviously. It was very easy to pull the paper from him, and he had here ulnar claw. Here's another case of leprosy, and this was a very unique case. This is called Lucio leprosy. It's a phenomenon. Sorry. Was it anything I did? How are we on time? Okay. This phenomenon was described by Dr. Lucio, and it's actually, in Spanish, the word is lepra manchada. So you look like a spotted leopard. And it's a very rare form of leprosy to see. So we were very fortunate to be able to see this on one of the last days of rounds. You can see he had amazingly, a lot of bone resorption. His hands were deformed. And he had a lot of necrotic tissue as well. So as we looked closer, this was a video actually, but I'm not going to be able to show it to you. But here is actually where the little larva was. And you can see that we took it out. And we were amazed. He was full of these, of myiasis. And the type of myiasis that was affecting him was the species Cochleomya omnivorax. And that favors infected or necrotic tissue. So we were pretty excited to pull one of those away from him.
We are so twisted. So that's not part of leprosy itself. That's myiasis on top of leprosy.
Yeah, he had a secondary infection. So he had, secondary infection with myiasis. So. And he had them all over. He had hundreds of them. So it was
basically fly larvae that stayed in necrotic tissue.
Yeah. Well, we're in the business. Leprosy has never been able to grow in bacterial meat or culture because it replicates too slowly. It usually takes about 13 hours to replicate, but the reservoirs are usually 9-banded armadillos. There have been serological tests that have been developed, but they don't have sufficient sensitivity and specificity to be used as diagnostic tests. What we have is doing a skin biopsy to make a definitive diagnosis. And what I saw being done is a slit skin smear test, which is to see basically if bacilli are in the area of where those bumps are. So this patient that we had with myiasis, his ear actually had bumps just like the first man that we saw, and they actually slit it and they put on a slide whatever came out, and they actually sent it to the lab to be stained, and I think he had 5+ of bacilli. And he also had places where we tested him for sensitivity, and he had loss of sensation. So the treatment of leprosy, it depends if it's paucibacillary or if it's multibacillary. Paucibacillary means there's not that many bacillus there. They usually the World Health Organization recommends dapsone, 100 milligrams a day, and that's self-administered by the patient. Then you have rifampin, 600 milligrams once monthly, and that's by direct observation treatment. So they have to come to the hospital, and we administer that medication to them and make sure that they actually take it. And the duration... Excuse me? Yeah, rifampin, they take the dapsone every day, but we give them once a month the rifampin, and the both of them. So we have to see them. This one doesn't have to be, visualized, but rifampin does. And the duration of treatment can be for 6 months. The multibacillary, so we have a high bacillary load. Here we're going to have the same kind of treatment, dapsone and rifampin, and we also add clofazimine. So clofazimine also is a directly observed treatment, and it's also self-administered. So we see them take this, we give them the pill, 300 milligrams once monthly. And the duration of treatment is 12 months. Before the World Health Organization changed their guidelines, physicians were giving these medications for 24 months. So then we have hydatid disease, which is also known as echinococcosis. And this was a patient I saw in Cusco, and she had a cyst in the lung, and she also had seeding in the abdomen. Her case was really sad because what they really wanted to do for her at this point is just something, just to help her breathe a little bit better. This was another patient who had a cyst that had a little rupture somewhere, and you can see that the membrane of the cyst, the internal membrane, actually collapsed, and it's radiolucid because there's air in that cyst. This one is still intact. Here I am seeing, this is the patient who she had the first x-ray that was intact. So we were listening to her because she was going into surgery to have the lung cyst removed the next day. So this is the life cycle. The definitive host is usually a sheepdog and the sheep. And what happens is that a lot of farmers in Peru, when their sheep die, they end up giving the sheep to be eaten by the dogs. And so that's how the dogs get it. So really, humans, we just need contact. We don't even need to be near sheep. If you have a dog or you have contact with dog feces, you can get this disease. So obviously, the parasite affects the liver and the lung mainly, although it can go to the brain as well. This is the adult parasite, which I was lucky enough to learn how to take under the microscope, pictures under the microscope. And this is Echinococcus granulosus. There are other species of Echinococcus, but this is the only type that exists in Peru. And here you see on pathology, you see that this is a cyst that was removed from a lady, and the millions of daughter cysts inside. Okay, so this liquid probably has hydatid sand, and if you look closely, if you're in person, you can see the actual gritness of the liquid. So you see the sand, and you would need a microscope to see the scolices and the hooks and whatnot. And here you have, if you touch them, they actually have the consistencies of a bubble bath bead. So here we have two other specimens. We have lung, and this was the membrane of the cyst. And this is liver, and you can see how all the little crevices that this disease makes in the liver. So the presence of a cyst-like mass in a person with a history of exposure to dogs in an area where Echinococcus granulosus is endemic is always suggestive of cystic echinococcus. You use imaging techniques such as CT, MRI. It's very easy to see. X-ray, you just saw those two X-rays, to detect the cysts. And after they've been detected, you can always confirm serological tests, but mainly they don't use them. So the treatment, it's funny because with them, there's a lot of controversy, both with hydatid disease and with neurocysticercosis, which you're going to see next. There's a lot of controversy. The internists want to manage it one way. The surgeons want to manage it surgically. And so this depends mainly on the location and size of the cyst. So if it's in the lung and in the liver simultaneously, they'll have a big fight between whether the liver cyst should come out first, if the lung cyst should come out first, and there's all kinds of debates. So what surgeons prefer to do is actually take out the lung cyst before the liver cyst. And the reason why is because they don't want their patient to be compromised. If they take out the liver cyst first, they don't want their lungs to be compromised in the surgery, so they prefer to go in and take out the cysts in the lungs. So if the lung has a cyst that's less or equal to 5 centimeter, we treat the patient medically. So we give them praziquantel and albendazole. The lung, more or equal to 10 centimeters, if the cyst is more than 10 centimeters, then you send them to surgery. You always give them praziquantel and albendazole after the surgery as well. Surgeons don't like you to give them this medical treatment before surgery because they say it weakens the wall of the cyst and that there's more chance of perforation. And hydatided sand is very anaphylactic. And the curious thing is when I ask them if they ever had cases of perforation, they have, but they haven't seen many cases of anaphylaxia happen due to the perforating cyst and the liquid going into the abdominal cavity. The problem is that it causes seeding in the abdominal cavity, and that wouldn't be adequate to do to the patient, because then you're going to have the patient infected for life. Percutaneous aspiration, injection, and reaspiration can only happen in liver cysts. And what they do is they inject saline, which is scolicidal, and what they'll do is they'll treat it that way percutaneously, and they'll inject the hypertonic saline into the cyst to kill the parasite. The next disease with a lot of prevalence in Peru is neurocysticercosis. And we have 3 pictures here. You have a calcified cyst, an intraparenchymal cyst, and an intraventricular cyst. Out of all of these, the ones that cause most seizures is the intraparenchymal. Intraventricular, this patient did not come with seizures, so they were actually discovered, I don't know, something else that they were actually looking in him, and they actually found this incidentally. So when you find this, what you have to do is remove it endoscopically. Because if this comes and actually, it acts like a plug, and then you can have hydrocephalus. So you want to put a shunt in this patient and then remove it endoscopically. So neurocysticercosis is actually one of the top causes of newly adult epilepsy in Latin America. So here's a life cycle, and a common misconception, which is funny to hear from people who are in healthcare, is, don't eat infected pork. And, well, that's true. You don't eat infected pork because you can get cysticercosis. But usually eating the infected pork will give you intestinal I forgot to pronounce it, tyaniasis. But if you eat the solium egg, then you get the neurocysticercosis, because the egg is so small it can be filtered by the liver. And that's how it bypasses and goes to the brain. So this is the adult emerging from the cyst. We saw all of these in the lab, in the parasitology lab. Here's all of little cysts. You can see the same thing happening here. And this is the brain of a rabbit, which is full of cysts. This was a case of an older woman who had cysticercosis, and her story is very sad because her eyes were normal before she was treated for cysticercosis. What happened is, you can see in the CT image, she had a parasite living in the eye. And her primary care physician didn't think of checking her eyes. And Dr. Gotuso actually showed us this case, and he said that the importance of, when you're treating cysticercosis, is to make sure and check their eyes. Because if they have a parasite living in the eye and you treat them, you're going to create such inflammatory reaction that they're going to lose their eye. So it's important for them to go to the ophthalmologist and have their eyes checked. And the only way to remove this or to treat it is actually by surgical removal. So the diagnosis of neurocysticercosis is by CT or MRI, as we saw. And you can also perform other tests such as serology, Western blot, which is highly sensitive and specific. People with multiple cystic lesions have more bands on the Western blot. And then patients reacting to 1 or 2 bands usually have a single granuloma or calcification of the brain. So what is the consensus on a calcified cyst? Nothing. You don't treat them. The parasite is dead. Everybody agrees about that. Everybody agrees about this one. The treatment, if you have 1 to 5 cysts, you give them steroids, you give them anticonvulsants, and you treat them with albendazole and or praziquantel. If they have 6 to 100 cysts, you admit the patient, you give them steroids, anticonvulsants, and albendazole and or praziquantel as well. And this is where everybody wants to fight, because you have a patient with this type of lesions on the brain, and everybody wants to do a different thing to the patient. But what the most Dr. Hector Garcia, who is the expert in Peru on cysticercosis, says if you have more than 100 cysts, this is considered cysticercotic encephalitis. So it's not an emergency to treat the parasite anymore. It's an emergency to treat the patient because you need to give them high-dose steroid because of the edema in the brain. Give them anticonvulsants and supportive treatment with mannitol to decrease the cerebral edema. Another disease which is devastating is paracoccidioidomycosis, which we don't see in the U.S. This is mostly distributed in Latin America, and Brazil presents 80% of the cases. Exposure to fungus habitat is most common. People who live in the jungle will get this. And for some reason that nobody knows, it affects more males than females on a 14-to-1 ratio. There's pulmonary involvement. That's how you acquire it, because you actually inhale the mycelial form of the fungus, and it affects the skin, and there's mucosal involvement as well. And this, in comparing it with leishmaniasis, which is painless in the beginning, this is actually very painful for the patient. So systemic involvement can occur as well, as we're going to see in a patient that had affectation to the bone. There's two forms of this disease, acute or subacute, or juvenile form, which are very rapidly progressing form, and the chronic or adult type, which can be unifocal or multifocal, and that's more of it's not as rapidly progressive as the acute form. This is a case of a man. I met him post-surgery, and these were pictures. Obviously, this is a picture of a picture because we didn't get to see him when he was actually infected. But he remembers having some kind of lesion on his face 2 years prior to this development. So this was actually a rapidly progressing disease in him. So he must have had the acute form. Here you can see lesions on the chest. I mean, this man is 63 years old. He looks pretty, healthy for his age, except for this infection on his face. So obviously all of this had to be resected, his whole mid-face. You can see the ectropion here. He walks around today with a mask. Obviously, with the way he's left, he can hardly breathe. His mouth is very small. It's very hard for him to eat solid foods, so we're actually trying to get some help for him. And, you can imagine with this type of problem, he walks around and he has grittiness from all the pollution. It's a sad case. But this is what he looked like after the necrotic removal of tissue. So the route of transmission is inhaled, and this was his x-ray on admission. And this is pretty curious because paracocci likes to stay mostly at the basis, and it avoids the apices, the reverse of tuberculosis. Paracocci brasiliensis is the organism, and this is how you actually diagnose it, by KOH and biopsy. And the lesions are called Mickey Mouse lesions because there you see the Mickey Mouse with little 2 ears. And these are budding yeasts. Okay, this is a female patient. She's very young. She's 18 years old. We didn't get to see her. We actually saw her as a cured patient. But she started with all kinds of complications, and there's actually literature on her that they published. But you can see the lesions that she has here. These were painful to her. They were like little ulcers. And this was just like an enigma because they tried looking and looking. They were suspecting that she had paracocci. And finally, one day, they realized that she had fluid coming from her lacrimal duct. And they took a specimen, and sure enough, they found Paracoccidioides brasiliensis in the fluid of her tears. They were very happy about that. But they were seeing that she had, prior to that, they were seeing that she had this massive visceromegaly. I mean, look at the spleen. This is just like, we never saw anything like that. So to them, they were very amazed how it can systemically affect a person. And eventually she got also, her sternum was involved. It went to the bone. So she had a partial sternectomy, and she's alive today. So they treated her with itraconazole, 100 to 200 milligrams daily, and I think she was treated for about 12 months because she was a very unique case. So one more case. So I'm not going to tell you what the diagnosis is, but this is painless itching plaque with diffuse infiltration of the face. You can see the patient got treated for it and got better. But but the patient isn't alive. She died. This is Balamuthia. It's a free-living amoeba. So we're seeing this with a lot of frequency. It's an emerging infectious disease. In Peru, there seems to be certain areas that are endemic for Balamuthia. This is the answer. This is the life cycle. And it's believed that Balamuthia, out of the free-living amoebas, Naegleria and Acanthamoeba, are usually acquired from water sources. But Balamuthia actually, they don't give cutaneous infections. But Balamuthia does give cutaneous infections. It's more often seen in the soil, but it can be also from water. This is a child that was treated with itraconazole and fluconazole, and you can see how the treatment actually helped her out a little bit. And this was the report. This is a report that they made on a patient that I saw already treated. She's the only case in Peru that had Balamuthia as a cutaneous infection, had spread to the CNS, and she got cured. So she's 5 years cured already, but she's an amazing case that they actually published, and it's called Successful Treatment of Balamuthia, Infection with Extensive Neurological and Cutaneous Involvement. And who was involved in this was Francisco Bravo, who was the dermatologist who diagnosed her at the IMT. So this patient, she was 21 years old, and what she had was, her history was that she had a fall in front of her house. And she is from Lima, and she started with this lesion right here, and it started spreading to the rest of her knee. So they had treated her as the prior girl with albendazole and fluconazole, and she had some kind of, some resolution to her problem. But after a few months, they realized that she had this lesion on imaging. So obviously they wanted to save her, and they started adding miltefosine. And miltefosine is actually an anti-leishmanial drug, and that was actually, they didn't know. I mean, nobody knows what kind of drug regimen to use with these people, so they use all types of treatments. They use albendazole, a combination of fluconazole or amphotericin B. They've even used in Brazil trimethoprim sulfa. So this is the amoeba on biopsy. And a curious thing is that it likes to live in the perivascular areas. So the diagnosis can be made by PCR. I think in diagnosing the case of this young woman who they helped cure, they sent samples to CDC so that the CDC could help them. And so they treated her with miltefosine, with albendazole, and with itraconazole. And that's how they helped her. But these are the combinations that you see in all types of patients with Balamuthia. And that's the end. I hope you enjoyed the presentation. This is the Gorgas class. There's Dr. David Friedman and Dr. Gotuso, who I owe a lot for the opportunity of being able to go to Peru, seeing these unique cases and bringing them back to you. And they have an expert course, which I hope to go to someday. And if any of you are interested in going there, you can talk to me, and I can tell you how you can apply and get training with them. But you learn immensely, so that's it. Any questions?